Well, hello and welcome back to everyone after our AGM, which was a great success, which is very good to know. Anyway, as you can imagine, we have been pretty well inundated with a number of questions, some in advance, some this morning, and some still rolling in. So I'll certainly do my best to group things together where I can to cover several points, maybe on the same topic. Might save some time. Could we maybe start around the eyes again? The eyes are getting a lot of coverage. And one of them is around Xylem ointment for use for severe dry eyes at night, but are there alternatives?
Yeah, there's a number of them on the market, and it's a question of finding what suits you, and different ones suit different people. There's Xylem, as you said, there's Hylo Night, which we used to call Vita Pos, which is made by Scope Ophthalmics, who are the same people who make Hylo Tears and Hycosan, and that's a really good product. And it's preservative free, like all of their other products, and was rebadged. I think for marketing purposes, it changed its name. And then you've got to bear in mind that different trusts and health boards stock different ones. So the reality within the NHS nowadays is that they're always looking to save money where they can in order to have money to spend on other things. So our trust, for instance, has moved to a product called HydraMed, which is also a very good moisturising nighttime eye ointment. And it's really just a question of working out which one suits you the best. Now, some people are lanolin sensitive, and you can get some lanolin free products. I think HydraMed sensitive is the lanolin free product. So you just need to be aware of that. So lanolin's a wool fat, and some people react to that. So if the first product you try at night doesn't work for you, try switching to a different base product.
Okay, thank you. And still on the eyes, how is it possible to get a referral for serum eye drops?
Oh, autologous serum. Now that is difficult. So autologous serum eye drops are probably regarded as the creme de la creme of eye drops, because what they are is they're spun down blood products where they take out the cells and you're left with the plasma, the sort of slightly yellowish fluid. And of course, the beauty of that is it's a natural product and it contains lots of things other than just liquid. So good antibodies, etc. Now there are two different forms. There's where they spin your blood down and give it back to you as eye drops, or where they spin donor blood down. And some of you who are really up on the media and so forth, about 12 months ago, there was a bit of a publicity in the media about how male blood is better to produce eye drops than female, and that's because female blood contains estrogens, which aren't so good for the eye. Now, it is difficult to get. It's only made in very selected centres, 2 or 3 across the whole of the UK, and you would need a referral from a consultant ophthalmologist, and they would have had to show and demonstrate that you had tried and failed all the other available treatments before they were referred on for that. So not easy, but in a very select few patients, very good.
Okay, thank you. Just on the question there of estrogen, when you mention it, we've had a few questions about vaginal dryness, and whether or not an estrogen-based cream or indeed other creams may be useful.
So yes, vaginal dryness is very common. You've got to bear in mind that we all get a little bit drier as we get older, particularly when you go through the menopause, and there are hormonal effects. Even during your premenopausal years, you'll find at some points in the cycle, you might be a little bit drier than others. So I normally recommend a combination of products for vaginal dryness. So I usually recommend that patients have an estrogen-containing cream or pessary. And again, your GP will have their favourites, and the ones what our trust use tend to be Vagifem, which is a pessary, and Estrogel, which is a cream. But you know, the make doesn't matter; it's the containing product that matters, and which you use topically. Now you use that in a certain way. So when you're prescribed an estrogen-containing product, you should ideally use it every day, every night is the best time, for about 2 weeks. And the reason for that is that what happens when you're lacking estrogen down below is that the genital skin becomes thin. And if you've got thin skin that's then dry, it can crack and tear, and that's really very unpleasant. So what I say to patients is you need to use the estrogen-containing product regularly, every night, maybe for 10 days, 2 weeks, and then as maintenance thereafter, maybe twice a week. But on top of that, you need to add a moisturiser. Now, you cannot use any old moisturiser down below, you do need to use a pH balanced moisturizer. A healthy vagina is acidic, so you need an acid-based product. And there are lots of them on the market. You can buy these over the counter. So yes, VM would be one of the market leaders, but there's Hyalo, Fem, Replens, and a number of others. The key thing is though that the estrogen has to come on prescription, so you'll need your GP's help with this.
Thank you. It's an area I think people don't talk about.
No, but they should
due to embarrassment.
Yeah,
but clearly, it's bothering a number of people who sent in their questions. Can I ask a little bit about being monitored, perhaps by a rheumatologist when expecting a baby? Is this something you would advise?
Yes. Now, expecting a baby is a very precious time of life, as those of us who, and you will have had children will know. So there's a couple of messages about Sjögrens and babies. The first message is that fertility is normal in Sjögren, so you are just as likely to get pregnant as the next individual. And the second thing to bear in mind is that there are reports of a very slightly increased risk of miscarriage in Rho positive patients. It isn't a big risk, but there is a slightly increased risk. But you're still able to get pregnant thereafter, so do persevere if you're unfortunate enough to suffer that. Now, there are a couple of very specific things that you need to know about pregnancy in Sjögren's, which are mostly applicable to the patients who carry the Rho antibody. So we have talked about Rho antibody today a little bit, and Rho is the protein or the antibody in your blood that's a very specific marker of Sjögren's, and about 60 to 70% of patients with Sjögren's will carry it. So not everybody, 60 to 70%. Of those patients who carry Rho, in most women, they go through pregnancy with no problems at all. However, in about 5% of cases, the antibody crosses the placenta. Now, the placenta normally acts as a bit of a sieve, and it sieves out things it doesn't want to get into the baby. But unfortunately, Rho is very tiny and it can slip through and get into the baby. Now, if it gets into the baby's circulation, in about 5%, so 5 in 100, so small numbers, it can cause one of two problems. One problem is called a neonatal lupus rash, and that means that when the baby is born, the circulating antibodies in the baby's system can react in the skin and cause a lupus rash. And a classical lupus rash is like a red rash on the face, usually in sun-exposed areas. We have had a couple of cases in patients of mine, and normally the rash appears a few weeks after birth and then settles spontaneously and completely by 3 to 6 months. And the reason for that is that the rash is caused by the mother's antibody, and the mother's antibody gradually gradually comes out of the baby's system over 3 to 6 months. So although it's a little bit alarming, it's not usually a major problem. A couple of top tips: keep your babies out of the sun, because it's the sun reacting with the Rho that produces the rash. And if they do get the rash, don't panic, but do seek advice, because sometimes the babies need topical creams, sometimes steroid creams to calm it down. Now, there is one other much more serious complication called congenital heart block. And this is where the antibody, again, gets through into the baby's circulation, but interrupts the conducting mechanism in the heart. Now, a normal baby's heart rate is around about 140 beats per minute, and that compares to about 70 in a normal adult. So they've normally got a very rapid heart rate. These babies' heart rate drops to about 48 beats per minute, so it's really quite dramatic. Now, it can be picked up when the baby's still in utero, still inside. It normally appears anywhere between about 17 and 22 weeks of pregnancy. If you've got past 23 weeks and you haven't got it, the chances are you'll never get it. It seems to be at a very specific time. It's commoner if you've also got thyroid disease. So if you've got thyroid disease and Sjögren's, which is quite a common combination, that increases the risk. If your baby is picked up as having it, it is very important that you're monitored carefully and that the baby is delivered in a specialist unit that has pediatric cardiology available on site, on call, because many of these children need pacemakers. Now, obviously, these are rare complications. A slightly more common problem I see is that women with Sjögren's tend to have slightly smaller babies, smaller birth weight babies. And there is a little bit of evidence that the baby's growth falls off a bit in later pregnancy. So we do recommend a little bit closer monitoring. I would recommend that you're booked in a consultant service, not a community-led service, and that your baby and you are monitored regularly. And sometimes if the baby's growth is falling off in late pregnancy, your obstetrician might decide to induce you a little bit early.
Well, there's a lot in there.
A lot to take in.
Yes, a lot in this. So I think as well, for those members who are expecting a baby, perhaps using the befriending service that we have where people can network together may not be a bad idea, because everyone will have a little bit of that picture, I imagine, and be very anxious to know as much as possible. Okay, thank you. A couple of questions have been arising around lip biopsies.
Okay, so
can it show up anything other than Sjögren's syndrome, and should you be worried if it does?
Okay, so I'll start by telling you what a lip biopsy is, because I do them. So they're used to help diagnose Sjögren's. So if you look at the Sjögren's diagnostic and classification criteria, the latest criteria say that to have definite Sjögren's, you either need to have the Rho antibody, which we know is only present in 60 to 70% of you, or a positive lip biopsy. And I think Ben in his talk showed some pictures of lip biopsies of the actual cells within the biopsies. Now what we do, because it's worth knowing what we do if you haven't had one, is that we take a piece of tissue from inside your lower lip. And the reason we do that is that we've all got 6 major salivary glands, 2 in our cheeks, 2 under our chin and 2 under our tongue. But we've also got 600 or thereabouts minor salivary glands lining the whole of the inside of the mouth and the oral cavity. Now they're closest to the surface and easiest to get at inside your lower lip. So if you run your tongue along inside your lower lip, you'll feel some like pimply sized bumps under the skin, and those are the ones we go for. Now, what happens when we take the biopsy out is it then gets put in a little pot and sent to the lab, where they slice it up into tiny wafer thin slices and look at it down a microscope. And what you're looking for to make the diagnosis is these clusters of inflammatory cells. And there has been a lot of research done on this. And what they've shown is that to have a definite diagnosis of Sjögren's, you have to have a cluster of at least 50 inflammatory cells within each high-powered field. Now, over and above that, we do see other things. Sometimes we just see scattered, non-specific inflammation, and that can be seen in a number of conditions. And we see it in smokers, for instance. We see it in people with viral infections, and we sometimes see it non-specifically in people with slightly inflamed glands. There are a couple of other very unusual conditions you can pick up on lip biopsy. So you can pick up a rare condition called amyloidosis, which is a condition where you have protein laid down in your tissues. And sometimes that can be picked up in biopsy. These are very, very rare, I have to confess. And I am only aware in my own personal practice, and I've done hundreds of picking up one. And the other thing you can pick up very occasionally is sarcoidosis, which is another very rare, unusual inflammatory condition. And I've even known of one case of something called IgG4 disease being picked up on biopsy. But all of these are very small print diseases, very rare, and there are other tests for them, but it's possible that you'd see them on biopsy.
Okay, thank you. If we could go back to our friends, the hydroxychloroquine, I can never pronounce it properly. Anyway, clearly there are a number of people using this, and they have a few questions about it. So I've just kind of grouped together. Do side effects, for example, like increased photosensitivity, outweigh the benefits of taking this particular drug?
Okay, so this can be a difficult question to answer, because everybody's an individual and different people react in different ways. And whenever we use any drug in rheumatology, it's always a risk benefit analysis, if you like. We've got to look at the benefits and the downsides. Now, I usually say to patients with hydroxychloroquine, there are 3 things to bear in mind. One is it does not taste very nice. It's a very bitter drug. It's related to quinine in tonic water. It has a bitter taste. And that does put some people off, and it can cause a little bit of nausea and a bit of bloating as well. But for most people, those are very minor side effects. The second common side effect is, as you say, photosensitivity. So it increases your risk of sunburn. It sensitizes you. That's not unique to hydroxychloroquine. That's seen with quite a number of drugs, including some antibiotics. So you've got to bear that in mind. Now, most people with Sjögren's, in my experience, keep well out of the sun because they find that they are very prone to sunburn in any case, and they're prone to develop rashes in the sun. So a lot of patients will say, actually, that's not a real bother for me. The third side effect, which is a concern, is this laying down of hydroxychloroquine in the retina. We do know that hydroxychloroquine is laying down in the pigmented cells at the back of the retina, and in some patients that can cause problems. Now, there has been a bit of controversy over this over the last few years. So when I started training as a rheumatologist many years ago now, the ophthalmologist said to us, you don't need to worry about hydroxychloroquine. It hardly ever causes this problem. It's very, very rare. And that was because we very rarely saw the end result of hydroxychloroquine toxicity, which is something called a bull's eye macula, which is an appearance at the back of the eye that can be seen by an optician or an ophthalmologist looking with those slit lamps for your eyes. However, over the last sort of 5 to 10 years, we have developed much better ways of looking at the back of the eye and much more sensitive tests. And there are 2 specific tests that we do now called an ocular coherence tomography, which is a very fancy, almost like a sort of scan of the back of the eye that shows the layers of the retina. And we also can do very high resolution visual field testing. And visual field testing is where you sit usually in a darkened room and they ping lights at you from different directions and you have to spot them. And what we can do doing those 2 tests together is that we can produce a map of the retina to look at how sensitive it is to vision. And what you find is that in quite a number of patients who've been on hydroxychloroquine long term, you start to see areas of the retina that are losing vision. So we now know that this is a commoner condition than we thought. It's still thought to be relatively uncommon, but the risk goes up with age and with length of time on the drug. So the current advice is that once you've been on the drug for 5 years, you should have a full assessment, including an OCT and a visual field test to see if you're developing problems. And if you are developing problems, you should stop the drug. Now, it doesn't reverse the changes, but it stops them deteriorating. And what we do know is that these tests are so sensitive that they will pick up changes before you're aware of them. So I think if you're contemplating going on hydroxychloroquine, you need to bear that in mind. I do know some patients will go and have tests done before that, and many opticians will offer you these tests on an annual basis, but you will probably end up having to pay for them at that stage. Whereas the NHS should offer you a test at 5 years. Now, you've got to bear those side effects in mind, and then you have to look at the benefits. Now, it depends what problems your Sjögren's is giving you, because hydroxychloroquine does not really help dryness. So you have to treat the dryness as a standalone problem. What it is aiming to help is the fatigue and the joint pain and the skin rashes. So it depends what your primary problem is. So I do see some patients who say, my only problem is the dryness, I just want that sorted. And then you wouldn't really consider hydroxychloroquine for them. But I see a lot of patients with fatigue and joint pain and aches and pains and rashes, and it is a good drug in that situation. You need to persevere if you're going to give it a go. So I usually say to patients 3 to 6 months minimum to see a benefit. If it's done nothing after 6 months, then you probably tail it down.
Okay, that's very helpful. We've had a couple of questions about the time span that someone perhaps should be taking the drug for, and luckily they are being referred for their OCT eye scans. So that's good news that it's working its way through the system. Can I ask you, we can't go through a talking heads without mentioning COVID.
No.
And the jabs. We've had a question, really, people asking several times about getting both the booster jab and the flu jab, and if it's good to have it done on the same day or have it staggered.
Well, that's really interesting, because actually I've just been involved in a study called the ComFlu-Cov study, which looked at simultaneously giving people their COVID booster in one arm and their flu jab in the other arm. And the results have been published literally this week in The Lancet, which is a very respected medical journal. And what it showed was it is safe to have them both together, and it doesn't increase the risk of side effects or problems. So if you're offered both together, by all means go ahead, because it is safe. The timing of the COVID third vaccine depends on a number of factors. If you are felt to be immunosuppressed, so bear in mind that there are certain drugs that immunosuppress you. That does not include hydroxychloroquine, fortunately, but if you're on steroids or mycophenolate or other such drugs that suppress your immune system, you are eligible to have your third COVID dose sooner than if you wait for a booster. Boosters are supposed to be given 6 months after your second dose. COVID third jabs for immunosuppressed individuals can be given sooner.
Okay, that's great, thanks. Still on COVID, we've had a number of people remarking about difficulties with sleep. And I know you referred to this about lifestyle earlier on, but particularly people struggling with insomnia, which is a horrible thing when you can't sleep properly, and added to the fatigue we can often have with Sjögren's syndrome, it doubles it up. Where people are maybe being prescribed melatonin, what's your thoughts on that? I'm looking for advice.
Yeah, so sleep problems are not by any means, as you know, unique to Sjögren's, but they are a worry to Sjögren's patients. I think, you know, if I look and I reflect on the patients I've been seeing over the last 6 months or so, many of whom have Sjögren's and lots of whom have other things as well, I think there has been very heightened levels of anxiety amongst the population as a whole. I've seen patients who've said to me that they're very worried about COVID, patients who've been shielding, who are worried about coming out into the real world, patients who are worried about the future for them and their families and their children and so forth. So I think anxiety makes sleep patterns worse. I think also there's this issue about day-night differentiation. And if you've been locked indoors a lot, you may have lost that a little bit. So for instance, this is a big problem in patients on intensive care units. So patients who are in intensive care units for any length of time lose their normal day-night sleep patterns. That's because if you're in an ITU, if you work in an ITU, you'll know day and night are not much different. Things are the same, you know, the ward's going all the time and the nurses are coming in and out all the time. So people kind of forget when it's day and forget when it's night. Now, melatonin is a drug that, well, it's not a drug as such, it's a naturally released hormone that is important for sleep patterns. And in fact, you can buy it over the counter in the States, because in the States, they use it for jet lag. And jet lag is a disruption of your day-night sleep pattern. So there is a logic to using melatonin to try and recreate a day-night sleep pattern. So, you know, I often recommend that patients trial it. It does help some people. Sleep can be very difficult. I think my first message about sleep would be to try and stop worrying about it. So there's good evidence that as we get older, we need less sleep. So if you look at sleep and the need for sleep, the individuals who need the most sleep are babies and teenagers. And the reason for that is you need your most sleep when you're growing. So sleep is when you grow. If you deprive a teenager of sleep, they will end up short. If you deprive a baby of sleep, they won't develop properly. But actually, oldies like myself and in many of the audience don't really need that much sleep. I think, you know, you can get away with less. And I think I've certainly noticed as I've got older, I've slept less. But I think what I would say is getting into a good sleep pattern is really important. So it is important you have a set bedtime and a set get up time. It's important that you calm yourself down late at night. So bad things for sleep are mobile phones, any screen of any sort. You need to acquire a very boring book, and you're allowed a boring book, but you're not allowed anything else in that hour before bedtime. You need to make your bedroom as calming an environment as you can. And many of you I know will be mums and parents. And if you think back to when you had a baby and how babies don't always sleep when you want them to, do they? And you teach them, you train them, you know, you calm them down, you turn the lights down, you give them a warm bath, you don't play exciting music, you give them a milky drink. There was a really interesting study published probably about 15 years ago now, looking at nursing home residents and comparing giving them a temazepam, a sleeping tablet, with giving them a Horlicks at night. And actually the Horlicks was as good as the sleeping tablets. And what that showed was that we have a deep ingrained memory of going to bed with a warm milky drink. It doesn't have to be Horlicks, it can be whatever you like. So I think actually getting yourself into a good pattern is important. And also doing enough exercise during the day to wear yourself out. So we need to tire ourselves out a bit. And again, the evidence shows that all of us need to do 30 minutes of physical activity a day. Now, that doesn't need to be running a marathon, it doesn't need to be even going for a jog, but it does need to be enough just to get your heart rate up, but still able to speak in a full sentence. So that's my advice to patients. 30 minutes of exercise, sufficient to get your heart rate up, a milky drink at bedtime, a good nighttime boring book, The Poems of Hiawatha is particularly boring if you're looking for one, and I've never ever finished it. And a calm environment. Take the screens out of your bedroom.
Thank you. I must look up that poetry book. I think it would do me some good, although I do tend to sleep pretty well. There's been one or two questions, though, about the balance between exercise and sleep. Some people find when they do some exercise, they're absolutely wiped out for 2 or 3 days afterwards. And other members are saying, well, actually, I get maybe an hour of bed rest in the afternoons because I'm, late 70s or so, and worry about that. I think it's the guilt.
Oh, don't feel guilty. I think you have to work out what works for you. We're all individuals. We all have our own pattern. It's a balance. Life is a balance. It's a balance between having enough time to do things you enjoy and enough rest to make them enjoyable. You don't want to do too much and not be able to enjoy the good things. And, it's a bit like a diet, isn't it? You wouldn't just eat one thing. You do a little bit of everything and you balance it out during the day.
That's fine then. Hopefully these people can rest easy now in their bed. And others are sleeping maybe 12 hours at a time because they're completely fatigued by things. But you're right, we are all different. And I think I too have found that things change over time as well as you age. There are different things there. Another couple of sort of standalone ones. How can I persuade my GP to refer me to rheumatology? We've had issues, sometimes people struggling to get a referral, or indeed, once they get to see a rheumatologist, they can't maintain the appointments. The rheumatologist dismisses them in favour, if you like, of others coming through the system. Any advice on that? So
it's a very difficult, and it's a big challenge at the moment, particularly as you might know. The NHS is under huge pressures UK-wide, and it's certainly worse in some areas. Vivienne lives up in Scotland, and she will know that Scotland is the worst supplied, that it has fewer rheumatologists than any other region in the UK, I'm afraid. So that makes it particularly difficult in places like Scotland. So it is a difficult one. I think what you've got to do is you've got to think to yourself, what added value am I getting by going to see a rheumatologist? So if your primary problem is dry eyes and mouth, almost all of that can be managed by you and your GP and optician. If you need a diagnosis, you may well need to come and see a rheumatologist to get that diagnosis. And then in terms of follow-up, that's a difficult one because inevitably there's more people want to see us than we've got time to see. And we have to be quite clear that we can follow up patients with definite Sjögren's, but the patients with sicker, just dryness, which I know is just as bad, doesn't always warrant ongoing follow-up. And the reason for that is what we have to ask ourselves, what are we doing? What difference are we making? Are we any added value? And in terms of added value, certainly in the patients with confirmed Sjögren's, there's a value to seeing them to rule out things like lymphoma in the longer term and to monitor things like their thyroid function. But sometimes if you get a good plan from a rheumatologist, at day one, you can stick to that plan and you and your GP can maintain that long term.
Yeah, I mean, the whole self-help thing is
increasingly
important, I think, for everybody accessing NHS, regardless of your particular condition these days, isn't it? Thinking to Glasgow at the moment, we've got the COP26 coming up.
Yeah.
So this has elicited, I think, one or two people asking some eco-type questions, not just the one on veganism that we had.
Shall I answer that? Because actually I did a bit of Googling. There is no good plant-based source of vitamin D, I'm afraid, apart from mushrooms, apparently. But I think you'd have to eat a lot of mushrooms. So, but however, fortunately, Boots do a vegan-friendly vitamin D. I've looked it up. Boots do it. It's quite good value.
Excellent.
Okay.
And people have been asking as well about farmed salmon because they're maybe not quite so keen on some of the press that's been going around with it. Could you, for example, eat something like trout, and would it have the same kind of nutritional value, do you think, when we need to look for our source of omega-3?
Omega-3, I see what you mean. So omega-3 is definitely very high in salmon. It is higher in farmed salmon than in wild salmon, bizarrely, and that's probably to do with the diet that they feed the salmon, I imagine. I think there are some it's a difficult one, isn't it? Because you could argue that farm salmon might be environmentally more friendly than wild salmon, because why would you pull wild salmon when you can eat farm salmon? It is a difficult one. But in terms of omega-3 is also in eggs. I mean, I keep chickens, so you could keep your own chickens, and you know exactly what they eat, or go to your local farm shop and buy them there. There is a big move away, you're right, absolutely, from things like caged animals and, and organically, and move towards organically sourced and vegetables and so forth. The best vegetables are the ones you grow yourself. And I know that's not possible for everybody, but I think lockdown has led to a lot of people picking up allotments and digging up bits of their garden. And even on a windowsill, you can grow things like basil on a windowsill, which is very nutritious, and salad greens on a windowsill. So I think just think about where you're buying it from, support. I'm a great believer in supporting local businesses. If you've got a local greengrocer, go to them rather than to the supermarkets. Greengrocers tend to give you things in paper bags, whereas the supermarkets wrap everything in cling film, I've noticed. And it's little steps like that, I think, that make the most difference, and we vote with our feet. So if we all start moving away from mass produced to locally sourced, that would be a good thing.
Yeah, we can't quite see the basil on my window at the moment, just out of shot. Unfortunately, the coffee's showing right enough too much of that every day. I think it is all about trying to strike that balance, isn't it, between, if you like, knowing what can work for you and being worried about giving it up because of other pressures such as climate change pressing on people's minds. And it's how we can maybe create a balance there. I think we've more or less covered most of the questions. Can I say that for one or two others that have come in, we will do our level best to answer these on the website or indeed in the next upcoming newsletter where we can. But I think, Liz, you've given us a very good a lot of your time today, everything from our Pilates teacher to answering all the questions and presenter. So thank you very much for that.